Hospital and through this introductory webinar and helping facilitate the 3-day workshop in May. So today, we'll be going over a course overview, then what is knowledge translation and why it's important, talking about evidence, and then action model as a actually bring research into practice and start thinking about barriers and facilitators to change will set you up for the workshop at the beginning of May. Today's webinar are to define knowledge translation, understanding what it is and why it's important, discussion model, and how it can be used to bring research into practice, helping define your own project using the project outline, and theoretical domains framework, a way to categorize and think differently about barriers and facilitators to change. Now for the workshop is that we know that there's a lot of research that isn't used in practice, and to actually bring that research into practice. And Gold Coast University Hospital would really like to move forward in applying the knowledge translation into practice. And so the workshop is designed to really help you use the science in your own practice, both research and clinical. And the goal quality of your own project, thinking about behavior change and how to achieve outcomes. The work is going to include 4 major components. We have a reading, and we're making you read a large number of research articles. One of the things we've done is pull out the 2 to 5 pages from each of the key articles that seem to lay out some of these processes so that you only have to read the most important section. The reading list is 30 pages. You get access to almost 15 different articles across a range of different topics. We also have a webinar that we're talking through today to help you think through what you need to bring to the beginning of the workshop. We have a 3-day workshop are a lot of interactive activities and group discussion. So the goal is for you to work through your own project over the 3 days in small groups, feed back to everyone else, and really apply the learning directly to the things that you are working on. So the workshop are to understand the fundamentals of knowledge translation and using the knowledge to action model. We'll talk similarities between quality improvement and knowledge translation. We're going to plan for rigorous implementation by understanding behavior change theory and how it relates to implementation, and to select and operationalize implementation strategies that you can use to actually support that kind of behavior change. On the third, that's how to bring it all together by using a logic model and then considering the context, because we know that the context really matters when we go through implementation. So helping you really think about what contextual factors should you consider. So we have our webinar and then the 3 days of the workshop. Think about what to implement and why people aren't changing, how to create change, and then how we bring it together and consider the context. Make the entire workshop even more relevant and applicable, we want to include the process and outcome evaluation to understand how people thought the process went and look at whether there are any changes in knowledge, skills, self-efficacy, and behavior from before to after the workshop. Include an evaluation that's a partnership between the Gold Coast University Hospital and the St. Michael's team to really assess all of these different aspects. We appreciate all of your participation in any of the process and outcome evaluation activities. Started today about talking about what is knowledge translation. This is knowledge translation from the Canadian Institutes of Health Research. And although the Canadian definition is very commonly used these days across the world, I've actually seen several Australians use this definition when presenting at conferences and stuff like that. So it's becoming a very commonly used definition. What's nice about it is it's quite comprehensive. It incorporates a lot of different elements. So first, how we need to include the synthesis, exchange, and communication of knowledge. So in other words, we make sure that we're synthesizing all of the available evidence to select what is the best available evidence. We want to share that evidence. And there's that dissemination is not a one-way street. The researchers share their findings with other people, but really an exchange going back and forth between researchers and the end users, and so that it really is a bi-directional relationship. And then apply that knowledge in practice. And we are really going to focus on over the workshop is how do we take all of this knowledge that is being synthesized and into practice, and to consider the context in which we're doing this, because it's within a complex system of interactions, and there are a lot of different people and levels of systems that affect how implementation actually plays out. So this is our vision of knowledge translation. Why does it matter? Why is it important? That it doesn't matter what field you're in, there's a large gap between health evidence and practice. And the topic you want to talk about, you can almost always identify very specific areas where there's research evidence that says we should be doing something. Practice is not actually what that research evidence is saying. From a broad level perspective, you know that 30% of patients are not getting treatments that are proven to be effective. And 20% of patients are getting things that might actually be harmful to them. Up to 75% of patients don't even get access to enough information to make informed decisions. And as patient-oriented healthcare, it becomes more and more important that patients have access to that information. When people actually are going to implement evidence in practice and implement programs, we aren't actually being used the way that they were supposed to be used. So they were originally intended. Or implementation quality to see whether they've actually implemented it the way they were supposed to implement it. We don't producing the outcomes we were hoping. And we also don't assess or plan for sustainability. And if we actually plan for how things are going to be sustained, then wasting our time and money because they're going to be short-lived outcomes that won't last over time. So knowledge is designed to address these kind of gaps to figure out how can we bring that research into practice. Another idea that we have research evidence, circle will happen, and all of a sudden it will produce outcomes. This is very common when we go out and do presentations for people and ask, how do you think this is actually going to happen? And there's just a belief that it will magically occur. But no, it's really helping us think about what is happening in that black box. How does the research actually come to practice? How can we support the process and really make it happen as effectively and quickly as possible? Is really to prevent the Isla-Giat principle. So in term that at these studies we don't want to end up in a situation where we feel like it seemed like a good idea at the time. We really and be thoughtful and mindful and planful before we start implementation, so we don't end up at the end of a project realizing that we've made lots of mistakes. And so the theory and evidence from knowledge translation from the beginning of our project, we can really try to prevent this kind of situation. Actually implement that evidence in practice. Well, the first is we think about what is the evidence that we are implementing. There are base terms that are floating around. I think it's helpful to really distinguish between some of the key terms to understand what is it that we are actually lots of evidence-based programs. These are packaged, programs being tested in randomized controlled trials, independent researchers, multiple times in different settings. And thus, they've been shown to be effective and impact behavior and outcomes. The standard of what we can implement. Unfortunately, there are very few evidence-based programs. Instead, we have a lot of evidence-based guidelines and evidence-based practices. And those is that they are providing a list of recommendations or practices that we would like people to adhere to. There is evidence that following those guidelines or those recommendations or those practices will produce outcomes. And evidence-based practices don't include the process by which we're actually going to change people's behavior. They don't know how we'll get people to follow those guidelines. They tell us what the guidelines are telling us to do. In content-based programs, bring in both elements. With a based guideline or an evidence-based practice, we all want to bring in evidence-based implementation or KT, evidence-based implementation strategies or KT interventions. So those are the ways in which we're actually going to change people's behavior to adhere to the guideline recommendation or the evidence-based practice. Have no evidence-based program. Another way to think about it is we will use the next best thing, which could inform the event program. A practice change that is based on evidence, the evidence-based guideline, your evidence-based practice, saying if people follow this practice or recommendation, they will get the outcomes they are looking for. We all want to embed implementation strategies that are also based in evidence. So on how to change people's behavior that have evidence they are also effective. And we want two pieces together using theory, specifically behavior change theory, by understanding why people would or wouldn't change their practices and picking the strategies to directly address those practices. If we think about a practice change or a guideline recommendation, like making sure that healthcare providers get a flu vaccine, that practice change, implementation strategy. So worked with several committees where they've selected implementation strategies like the use of reminders to remind healthcare workers to get their flu vaccine. A reminder is an evidence-based strategy, and there's evidence that shows that reminders are effective at changing practice. They're really going to work if they're tapping into the underlying reason why a person might change or not change their behavior. This is really not one of the primary drivers for why people are choosing not to get the flu vaccine. The user is probably not going to change practice as much because it doesn't tap into that underlying behavior change theory. Understand why people would or wouldn't change and pick strategies that directly address that change and evidence that they work. Might say to themselves, well, we want to do these things, but we either don't have enough evidence for what we're doing, or what if the implementation strategy doesn't have enough evidence? We like to think about evidence along a continuum. So we have evidence-based programs. These are pre-packaged programs that have been tested in randomized controlled trials and shown to be effective. We have a high level of confidence that this will produce outcomes because of the way in which we have tested and kind of determined that this program can produce outcomes. So these programs aren't available, which means we want to go to the next best thing. Evidence-informed, theory-driven programs come in, where we can link together the evidence from all pieces and use theory to link them all together. Sometimes we're implementing implementing things that we call promising approaches. So the areas where we have a little bit of evidence, but it's not really high quality, or accumulating evidence, but we aren't there yet. This is true of things that were once current practices that are now being evaluated and slowly working their way up the continuum. When it comes to this, there are lots of things that we're currently doing that may be effective, but not be effective, and we just don't really know. So it doesn't stop doing those things. To just be aware that those things don't actually have evidence of their effectiveness at the moment. We also are ineffective, so that don't improve outcomes, and even programs and practices that are iatrogenic or harmful and might make us for patients. So we think about the continuum of evidence and the continuum of effectiveness. And our goal is to work our way further to the right-hand side to increase our confidence level that we will, in fact, produce outcomes. Sometimes we won't be able to make it all the way to the end of the continuum. It's really helpful to think through these things is to use an example. So to workshop, we're going to be talking about the MOVE example. MOVE of vulnerable elders. Initially evolved because we know that many patients, particularly elderly patients who are admitted to hospital, a lot of time in bed. And the spending time in bed rather than getting out of bed can make patients worse just because they've been in bed rather than because of the reason that they came to the hospital. So intervention and evidence-informed, theory-driven programs that incorporate clinical changes and implementation strategies and links the two of them through evidence. So the practice changes at the clinical level, relaxing mobility when people are sick, engage patients to be mobilized at least 3 times a day, and making it was tailored to each patient's needs. So for some patients, mobility might be just getting up and sitting in their own bed. Needed assistance, while patients are able to independently get themselves out of bed and walk around. So mobility tailored to the needs of each patient. And so implementing these strategies change patient outcomes. So we change patient and clinician behavior to align with these strategies, or with the practices. And that's implementation strategies coming in. So a variety of implementation strategies, the evidence they were effective, and to the practice changes using behavior change theory. So we're going to talk about how we actually did that when we start talking about the barriers and facilitators to change. Often, we use a process model. And it really helps guide us through understanding what are the steps or stages to bring research into practice. We use this model as our process model because based on a systematic review of over 30 theories of planned action. So synthesize the best available research on planned action, bring those all together into one model. You know the knowledge to action cycle is it not only embeds how we bring research into practice, but actually starts in the middle with how we synthesize the evidence. Part is called the knowledge creation funnel. We have knowledge inquiry, and essentially first generation knowledge. This is all the research studies that are out there, the thousands and thousands of studies tell us what are good practices, what is effective. But there's so much research out there that this is not really in a usable format, which means we need to synthesize and distill that information down. Use knowledge synthesis, like a systematic review or a rapid review or scoping review. But I've looked at systematic reviews before. They are sometimes very challenging to read and operationalize. And so we actually take systematic reviews often and turn them into practice, one more step by refining those through knowledge tools or products. For example, guidelines with guideline recommendations, decision aids, which are more actionable and can actually be used in practice. Focusing on these parts of the knowledge action cycle. But one really important to remember is that creating, distilling, and disseminating the knowledge. Use a guideline recommendation or an algorithm or decision aid. Do not have to actually change practice and change the outcome. We really need to implement effectively in order to make that happen. So to help implementation process, the side of the knowledge to action cycle and the steps that we use to intentionally and deliberately cause change. I want to provide directional arrows between each of the steps. This is a very iterative process where we go back and forth, working up, but often going back to revisit steps as we go through the process. So let's think through the different steps or stages, but we need to realize that it's not a one-way street as we're walking down, and it is very cyclical. And in fact, as we even reach the end, we often start to go around again. So over 4 to 5 years of using the knowledge to action cycle for a variety of different projects in different areas, one of the things that we've found is that people find it very hard to operationalize some of this stuff because there's not detail provided to really figure out what to do. One is we've kind of expanded a variety of the different steps in the knowledge to action cycle to make them more operational for us. Throughout the workshop on operationalizing the first half of the knowledge to action cycle. So from defining a problem to actually having something that we can turn around and implement. And in the same maps on to the different aspects of the knowledge to action cycle. So one, we'll focus on steps A, B, and C. Stage 2 on step D, and we'll focus on step E. So the whole workshop content. Right now, focus really on step A and step C today in the webinar. It will really help you come to the workshop with materials and the kind of thinking that will help move the workshop content forward a lot faster. So we're going to be thinking about defining your goals and stakeholders. So in talk about, sure we identify and consult with key stakeholders. So getting who are the key people affected by this kind of practice change, and make sure that you identify and work with them right from the beginning. Integrated knowledge translation, where we consider the needs of the stakeholders and actually bring them into the research team and research process. Consider the program's long-term goals. What are you really hoping to achieve? And then finding the actual practice change. The we used called the project outline helps us think through 7 questions that really lays out some of these components for each different project. So the assignment to prepare for the actual workshop will be to complete the project outline for each of the projects that will be discussed at the workshop. So the first question is your goal. What is the purpose or objective of the practice change? So what kind of impact do you hope to see? Thinking about those projects, our task is to think about improving patients' functional status at home rather than being placed, for example, in nursing care, and to stay in the hospital. Thinking about your own project, what long-term goals or objectives that you hope to achieve? These are far down the line because of the nature of the project. Long-term goals might even take years to achieve and thinking about what those are. For example, we're working on hand hygiene, might have reducing hospital-acquired infections as their long-term goal, which take many years to see, but that is a long-term objective they hope to achieve. Next, we'll think about where the practice change is taking place. So in our role, it's hospitals, and we could even describe the kinds of units where that's happening. They might take place across multiple different settings, those that might happen in the community. And so it's really helpful to think about where are all of the changes taking place. But who are the stakeholders who are going to change as a result of implementing this practice change? It includes nurses, like physiotherapists, occupational therapists, social workers, dietitians, physicians, volunteers. So we might be changes from all of these different key stakeholder groups, and we want to make sure that we engage them early on in the process. Next, we have specific behaviors or practices the specific behaviors and practices that each of the stakeholder groups need to make. So we really, as clinicians, thinking about what are the clinical changes that need to take place. The first, mobility is assessed and documented, so they know whether patients are able to be mobilized or not, and to what extent. Or encourage mobilization of patients at least 3 times a day, either actually moving them or getting them to move themselves. It should be tailored to the patient's ability. To consider the needs of the different patients at an individual level. This, for many people, the hardest step in going through this template is redefining what are the very specific practice changes that you need to make in order to implement this program or project. This one is probably the most important one because everything becomes contingent on understanding how people will or won't make these kinds of changes. What are their barriers and facilitators to making that happen? So spend extra time somewhere, I would definitely spend it on this specific question, really thinking about what changes that you expect for people to make and what practice they should be doing to make sure that's very, very, very clear. Then often people need to make this change. Some changes that are very infrequent. Other changes that are very embedded in the way that people do things. So this example is deeply embedded in their day-to-day lives. The idea that they would, during the workday, mobilize patients many times a day. And I think about the idea that each patient should be mobilized 3 times a day. Each clinic should be doing this multiple times throughout the day. They see different patients. So that's actually this new change. Whereas other changes might be less frequent. And so it's really to think about how frequently they need to make this change. Then we get the evidence for this practice change. We know that there's research to show that mobilizing patients can improve functional status, decrease length of stay, and increase the chances of returning home. Reciprocal, not moving and staying in bed, has many negative outcomes. For example, patients lose 1 to 5% of muscle mass for each day that they lay in bed. So staying 2 weeks in the hospital can be very detrimental, particularly for an elderly patient. You can think the evidence for your own practice change. That might come from a variety of different sources, like clinical practice guidelines, systematic reviews. There are a variety of different ways that you can think about what is the evidence for the practice change that you're looking at. Finally, who's actually going to be responsible and involved with making this change happen? So we having the units themselves are responsible for making the change, and we are supporting the different hospital units to make this happen. The unit that's participating would create an implementation team. Occupational therapists, physiotherapists, physicians, management, and those people are responsible for making the change happen, often by an education coordinator who really leads all of the activities. You can start with the people who would make change happen for your project. You might want to recognize that there might be multiple levels of change taking place. Sometimes you're expecting patients to change and clinicians to change. And so maybe this might have multiple different groups that you'll consider who be responsible for making changes at multiple different levels. Put the questions together in one big template so that how all of these pieces fit together. This really understands what is it that you're trying to achieve, who change, how do you want them to change, and really guides all of the next steps in going through the knowledge to action cycle. So this is a huge amount of time to go through, but it's really, really valuable to make sure that you've thought about it before you move forward with the next step. This project line, we start with some of the next stages. I'm not adding knowledge to the local context today. We'll talk about that more at the workshop. But jump ahead to understanding the barriers and facilitators to change. Because it'll be helpful if you start thinking about barriers and facilitators before you actually show up at the workshop. So there are kind of sub-steps within this First, we identify the barriers. Then we organize them and make sure we're focusing on barriers to that practice change, or question 4 in the project outline. And then behavior change framework. Your first is to focus on understanding what are the barriers and facilitators to change for that practice. A variety of sources. For example, surveys, interviews, focus groups, observations, literature reviews, and discussions with key stakeholders. They can be or informally, or a combination of those. Go to the literature. There are systematic reviews of barriers and facilitators. There's a Vanna article that looks at barriers and facilitators to guideline implementation, and identified 256 barriers to change. And so a lot of the barriers and facilitators that you have will be in that list, but you might have additional ones that are very, very specific to the project that you're working on. So you have a combination of these different pieces to come up with your list of barriers and facilitators. To make sure that you include some of your key stakeholders in this stage. Because sometimes we imagine barriers and facilitators, and the actual barriers are very, very, very different than those that we might anticipate. So over a few weeks, as we prepare for the workshop, it'll be a great opportunity to start having casual conversations with people around what might be the barriers and facilitators to change. Maybe observations, and dig deep into why people will or won't make the change for the desired practice change. For the MOOC, I presented a few barriers and facilitators to help give you an idea of the kinds of things that we might encounter. Our most common barrier that we ever hear is time. So in almost every project where people say, I don't have enough time. Although a barrier to change, we really have to dig deeper than that. Because if you don't have enough time really means you're not making it a priority. Why it is or isn't a priority. This barrier, start deeper and asking more questions to really understand why a person doesn't want to change. You might suddenly get answers like, it's a job to move patients, that's physiotherapists are for. Might also, I'm afraid patients will fall if I get them moving. This is one of the most common barriers that we encounter is they're afraid of something bad happening if they make a change. You might see if people are worried about some bad outcome if change in line with the new recommendations or practices. So learners and facilitators. So you don't just want to mention barriers, but also talk about some of the things that might facilitate change. For example, say things like, the decision to change and put a little effort in, I really saw the benefit. Paid off on their own most of the time. It was amazing. And we can also capture some of the facilitators to change because we really work to those strengths. A long list of barriers and facilitators. It's uncommon for us to have over 100 barriers for one single project, which is really daunting and overwhelming effort. So our next steps really help us narrow down those barriers and facilitators and focus on how we're going to actually use them to inform the strategies we select. To step C, assessing barriers and facilitators. We want to ensure that number says we're focusing on the individual barriers to the practice change. Got to think about why people would or wouldn't make that change. Number 4 on the project outline. We build barriers and facilitators to, for example, implementing an education. Because barrier facilitator, we'll talk about it at a later stage. This is focusing on barriers to the practice change. Then barriers and facilitators and map them to a behavior change framework. So we use the TF, or cycle domain framework. Based on a review of behavior change theories and consolidates them into 14 different categories. I find it a little bit daunting and overwhelming, but I find it one of the easiest to use because you actually have very little information to figure out how to categorize things. I like never have a test, so you don't have to memorize what they are. You can always have a little cheat sheet of what are these different definitions for the different categories. We map them in groups or at least pairs, so it's never one person who has to map it alone. And things might even map to multiple different TDF domains. And so it isn't that there's necessarily one right answer. There might just be things that fit better or less well. I looked at each of the different definitions for the different categories. Without those, I think that we could think about some of the examples and how they might map to different TDF domains. We're going to go into a lot more detail going through actually mapping the difference and facilitators for your own project. Don't get into the workshop, but then you can think about what are some of the barriers and facilitators before you show up, the more helpful the workshop will be. So think discuss. For the MOVES project, Bill said, it's not my job to move patients. That's what a therapist are for. So I'll give you these and think about which TD domain might relate to this specific barrier. All right, so I hope we're able to see that this might fit very nicely into the social and professional role. So that this might say, well, it's not my role to move patients. That's the job of someone else. We've also looked that this might be about beliefs about capability. That kind of is on people's perceived or ability to do something, or their confidence that they actually perform that skill. It would be an issue here where nurses might not feel confident in moving patients. We haven't explicitly said that. We try not to map it to something unless they've actually made that statement. would make too many deeper inferences. If that's really a key source, you might want to probe in that direction to get more information at different topics. Use the TDF to set up how you might ask some of your questions to make sure you've seen whether or not there might be barriers of facilitators in different categories. Example. People have just moving patients. If they will fall. What TDF domains might be relevant for this barrier? So we have questions like, or barriers like this to two different domains. We have beliefs about consequences. It's talking about something bad will happen, patients will fall. Emotion, saying, I'm afraid. And so there's no response that's happening. Or this is our most commonly encountered barriers. And we have barriers that map to this combination, belief of consequences and emotion. Something that's really special and amazing about being able to see how that combination plays out is that many times we pick implementation strategies assuming that knowledge and skills are the primary barriers to change, and that we give people the knowledge and we give them the skills that they will make a change. But a barrier to change is a belief about a consequence and an emotion. Giving people access to knowledge and the skills to do it is unlikely to change their practice and get the outcomes that you're looking for. So think about barriers and facilitators in this way really helps set us up to pick strategies that more directly address the reasons people are or aren't actually making changes. So going to such as a facilitator says the decision to change and put a little effort in, I immediately saw the benefit. Patients on their own most of the time. It was amazing. Which TDF domain is most appropriate for this facilitator? So often that this one to reinforce that because they change and they're seeing really positive things happening and reinforcing their behavior. We hope thinking about the different kinds of barriers and facilitators and how we're ultimately going to map them to the TDF might be you think about your own anticipated barriers and facilitators a little bit differently. Maybe think of how you could probe and ask questions with people who might be part of the expected behavior change and practice changes in moving forward with the project. Then, workshop will actually go into even more detail for all of the different steps to figure out how we take those barriers and facilitators and operationalize them in behavior change theory. So we really pick strategies that have evidence and are by theory. Workshop, we want to submit the project outline handout. You can think through your own project with people who show up to the workshop with more information on their project outline. We to get a lot more value out of the workshop and figuring out how to move their own project forward. We also have enough time to review people's project outlines, that we actually have some information about the project and then start to think through some of the next steps for individual projects that you'll be working on. So if you have assignments by Friday, April 8th to Melissa, and please email her if you have any questions, and provide feedback and work through these 3-day workshops. So just for learning objectives today, we talked about defining knowledge translation and understanding what it is, why it's important. The action cycle as our process model to inform all of our key activities. The theoretical domains framework as one way to think think about assessing barriers and facilitators to change. If you're up to the workshop, please feel free to email myself, Julia, or Melissa, the research coordinator for the workshop. Thank you for your time, and we hope you have a pleasant day.